Hi, it's Dr. Chris Sear, Chief Medical Officer for Telecare and the Acting Director of Renal Medicine at the Alfred Hospital in Melbourne. And today I'd like to talk to you about solving the public hospital waitlist crisis with a successful public-private partnership model of service. As the Acting Director of Renal Medicine, I'm becoming increasingly aware of the hospital waitlist problem that we face. And while there is going to be risk inherent with any new and innovative model, I believe that there is an increasing risk of doing nothing and letting our hospital waitlists balloon out. As an example of how bad our wait times are getting, if we look at the 90th percentile, which for waiting times, which is when 90% of patients have been seen, if we look at recent data from Queensland, the 90th percentile for seeing a pain specialist was 487 days, so 1.5 years. And the numbers aren't much better for other specialties such as rheumatology or neurology. Now looking at some Victorian data, which is where I come from, we see similar, if not worse, numbers. So for example, for dermatology, the 90th percentile for wait time was 616 days. And if you look at individual hospitals, the wait times can be as long as 7 years. Rheumatology, similarly terrible at 468 days state average, but St. Vincent's, you're looking at nearly 5 years before 90% of patients have been seen. So we rolled out this public-private partnership model in Mackay Hospital and Health Network. And you can see that Mackay, this network is quite a large network and a large area geographically. So from Claremont to Mackay, we're looking at 300 kilometres. So it's probably around 400 kilometres from one end to the other. So it's a very large geographical area. But if you look at the rurality of this area, you can see that it's predominantly modified Monash Model 5, 6, or 7, with only Mackay Hospital being modified Monash Model 2. So we're looking at quite a remote and non-densely populated area. Now, unfortunately, if you look at the distribution of physicians, it's no surprise that most physicians are in these major metropolitan centres or these MM1 areas with a significant amount in MM2, but the numbers really significantly drop off a cliff after that. And so there is a mismatch. We all know about telehealth since the COVID-19 pandemic, and a recent study in New South Wales of 2,301 patients who attended a public hospital outpatient essentially showed that telehealth was very well received by patients. So for most of these metrics, more than 90% of patients rated them either very good or good. And I'll just point out the last one, that if given a choice, 90% of patients would use virtual care again. We do worry about certain patient subgroups and how they respond to telehealth. But multivariable analyses showed that the experience was similar regardless of age, education, location, or chronicity of health condition. There were some factors which did affect the experience, such as if the patient had never seen the health professional before. So, for example, if it was an initial consultation, if the patient was non-English speaking, or for phone-only consultations rather than video. There were, however, significant benefits, mainly convenience and the fact that the appointments saved time. And patients generally felt a lot more comfortable in their surroundings. Now, going to the other side, so the supply side, if we look at physicians in Australia and how employed they are or how much they work, you can see that there is a subpopulation who aren't fully employed, who work 34 hours or less, or even a significant amount that work 19 hours or less. So there is opportunity to tap into this underutilized workforce if we can provide them convenient models to gain employment. So how do we fit all these pieces together? How do we tie this underutilized physician workforce with telehealth and a rural, poorly populated health network? And rather than tell you all about it myself, I'd like to invite Kathy, the virtual health manager at Mackay Hospital, to tell you about our unique private-public partnership.
Public-private partnerships, PPPs. There is a general view, at least in Australia, that PPPs don't work, and there are certainly many examples of failed attempts in the health industry. Today, I'd like to share a successful arrangement, a PPP that is helping Mackay Hospital and Health Service to manage specialist outpatient waitlist demand. Mackay is located in the state of Queensland, halfway up the coast between Brisbane and Cairns. The health service covers an area of roughly 90,000 square kilometres and services a population of 180,000 people. The Mackay Base Hospital is the hub hospital, and from here we run our specialist outpatient clinics for the entire HHS. We have a diverse population across 8 communities. They are coastal and rural outback centres built upon sugarcane, coal mining, tourism, cattle and fishing industries. Patients from our 7 rural communities are required to travel between 2 to 4 hours each way to access specialist services at Mackay. Because of this, telehealth has become well established, and last financial year we delivered almost 17,000 outpatient telehealth service events. As part of our telehealth service offering, we have established a public-private partnership model. To explain what this is, it is important to understand what it isn't. It is not outsourcing, which generally involves a list of patients being sent to an external provider who are then pretty much left to manage those patients as they see fit. Often, the health service doesn't even know a patient has received treatment until we receive an invoice from that provider. Under this arrangement, the patient remains on our hospital waitlist and we maintain full visibility of our patient for the duration of their care journey. It is not locum arrangements, which can certainly increase capacity for a short period of time. However, once the locum leaves, the service is back to where it was to manage waitlist demand. This is a long-term arrangement that ensures sustainability and offers our patients continuity of care, often with the same specialist for many years. Not a replacement of existing specialists or the services they provide. This model runs in parallel and supplements what we already do. It is not viewed as a separate standalone service. In fact, the telecare specialists have been accepted as an extension of the existing specialty practice team, and many of them are in contact with their in-house colleagues and discuss cases. Referral pathways ensure patients are referred between the in-house and telecare teams in line with the patient's condition at any given point in time. It allows us to offer patients more choice to be treated in the right setting appropriate to their care needs. So what prompted us to go this way? In 2015, Queensland Health embarked on the first long waitlist project. Basically, a lot of money was doled out to HHSs to rein in outpatient waitlists that had too many patients waiting outside of recommended wait times. All 16 health services swung into action. Mackay found itself in the middle of a bidding war for specialists through locum recruitment agencies and from within Queensland Health. Like many regional centres, we were on the losing end, with most specialists more attracted to places like Brisbane or the Gold Coast. So a decision was made to trial a service provided from the private sector. We started small, seeing only 39 rheumatology and neurology patients, but it worked well. Over 9 years, the public-private partnership has developed into what we have today. We have remained true to the original vision, to complement our existing services and capacity, to deliver full end-to-end case management, to ensure superior patient care and support. And we've designed a model that is agile and adapts to changing need, and that is proactive, sustainable and scalable. We have taken a unique approach to a long-standing problem. By turning toward the private market and no longer relying solely on the public sector specialist resource pool. By taking advantage of the opportunities virtual care provides, telehealth, which by its very nature lends itself perfectly to this type of arrangement. We've built robust contract governance structures, ensuring a collaborative partnership that remains true to a patient-centred ethos. Clearly defined KPIs and monitoring processes, partnering to develop the best workflows and technology systems to support operational need. Sustainment through having sound recruitment and onboarding processes, backfill and redundancy capability built in so that we can maintain service levels and increase and reduce in line with our demand. There are currently 4 service types in place under this arrangement. The Specialist Outpatient Service delivers clinics for 9 specialties with 26 specialists. The model operates alongside the in-house services, and our specialty nurse teams are heavily involved, running nurse-led surveillance clinics and supporting biologic medication management and diabetic education as examples. We have established referral pathways for procedures such as bone marrow biopsies, lung function tests, medical infusions, lumbar punctures, and sleep studies, to name a few. We have also introduced an inpatient specialist telehealth service, a visiting medical officer surgeon arrangement, and a remote respiratory reporting function. The arrangement can flip between public or private model in line with the HHS activity targets and cash flow position. Just this year, we've granted telecare access to our Queensland health systems. Now, telecare doctors can make clinical notes directly into their patient's Queensland Health electronic medical record. They can create pathology and imaging requests and view results just as our in-house clinicians do. Remote online training is provided by our digital hospital team, and each clinician is signed off as competent as part of the onboarding process. In April, we commissioned the Workflow solution. This is a shared scheduling and tracking portal, an administration dashboard that my admin and nurse team and telecare use to upload referrals and clinical updates, to schedule and track patient appointments, and to manage patient contacts via SMS, patient results, and specialist letters. With these digital tools, we have full visibility across the entire patient journey in real time. Patients are selected for the telecare service as part of the referral, triage and categorisation process. The referral is uploaded to telecare, who then engage the patient to schedule an appointment. Our nurse team ensure all the relevant test results and patient information is complete and available in the medical record prior to the appointment date. This ensures precious clinic slots, specialist and patient time is never wasted, in line with our commitment to delivering high-value care. When the patient has been seen, a specialist letter is provided to the referring doctor and saved to the patient's medical record. This slide shows the incremental increase in patients seen over the years and highlights a doubling of activity over the past year. We can attribute this growth to the close working relationship we have with telecare and the technology and workflow efficiencies we've been able to introduce. As well as an increase in patients seen, we are seeing a 33% material reduction in patients breaching recommended waiting times across the telecare service portfolio. The proactive approach to patient engagement is resulting in lower fail to attend rates in our telecare clinics. As an example of this model's effectiveness, the hepatology service has always functioned under a visiting medical officer contract with a specialist from a tertiary site providing 1 day of clinics per fortnight. A resignation in December 2021 meant that telecare provided the only access to hepatologists for a period of 9 months. We worked closely with our liver nurse team, who also run nurse-led surveillance clinics, and despite having no in-house specialist, the service levels were maintained and are now increasing. In the second graph, we can see the growth of telehealth delivered appointments. This data demonstrates that the use of telehealth can be very successful in maintaining services that have very limited in-person capacity. We've seen the same outcomes across endocrinology, rheumatology, and our inflammatory bowel disease specialties, where we've encountered in-house specialist deficits. Post-appointment, every patient is asked to provide feedback on their telehealth experience. 97% report positive satisfaction rates. To finish, I'd like to quote a couple of the patient feedbacks. Firstly, thank you. Your service has been absolutely faultless from the start of this process right through. Phenomenal service and vibe. Thank you. Finally, living rural, I could have the appointment without having to take the day off work due to driving back and forth for at least 5 hours. Brings my presentation to a close. Thank you.